right, we've made it to our last video. We're now going to do a few cases just to practice a few things, and we'll be done. I think I did put a workshop together for you too to do some more practicing with a few other things to kind of review this material. All right, so let's do our cases. So the first one is utilizing that generic formula that I said 140 minus age over 140 minus the age of a typical patient, which we're going to fix at 60 here. So levofloxacin is usually given as 500 milligrams once a day to a 60-year-old 70-kilogram patient with community-acquired pneumonia. So what are we going to give to a 92-year-old 63-kilogram woman? All right, we're using this generic formulation, but we're going to look and compare it to dosing recommendations in the next slide. So our new patient's dose rate, when compared to 140 minus their age, which is 92, over 140 minus the age of the typical, which we're going to pick this 60-year-old patient, they're getting 500 milligrams per day. So if we do the math, we're going to recommend 300 milligrams a day of the levofloxacin. Levofloxacin is given or is cleared by the kidneys, so we would expect to see a decrease in renal function within a 92-year-old. It'd be better to actually figure out their renal function, wouldn't it? So using the information that we have with assuming a serum creatinine of 1, and that she's a female, and that she's probably at or below her ideal body weight, although I guess we need to know how tall she is, but we can't always figure that out. So we're going to just go with this weight. So we calculate using Cockcroft and Gault an estimate of 35.7 mils per minute. Is that truth? No, that's a guess, right? We're guessing here. And to dose levofloxacin, here's our data from the literature. So we're going to be in the 20 to 49 mils per minute range with this 35.7. So we give a one-time dose of 500 milligrams. So that's like a loading dose, basically. And then give 250 every 24, which we came up with 300 using our generic. Since it doesn't come in 300s, we probably would have given 250 anyway. So 250 milligrams every 24 hours for this patient, or a bigger dose, but I would recommend this in this lady. Okay, so how about Mr. Johnson? Mr. Johnson is 84 years old, 73 kilograms, 5'9", serum creatinine of 0.8, taking Apiaxpan, well, let's just call it Eliquis because it's easier to say, 5 milligrams BID for AFib. So this is one of the direct-acting oral anticoagulants. He recently lost 15 pounds due to a poor appetite and has mild frailty. Remember, frailty is ability to resist injury when given obstacles. His Cockcroft and Gault creatinine clearance estimate is at 71 mils per minute. Well, the fact that he lost all this weight isn't eating, I would be worried about sarcopenia here. So how accurate is this serum creatinine, right? And how is Eliquis cleared? It's actually 3 different ways, which is kind of good because it's not relying on just one pathway. It's about 25% hepatic, but it is SIP system cleared, that 25%. It's about 25% renal, and then it's about 50% biliary. It is, like I said, SIP and P-glycoprotein substrate. So if you're giving enhancers or inhibitors of those things, you need to be a little bit worried too. So what kinetic and dynamic factors are influencing this decision? Should his dose be adjusted? All right, we need to know more about what normal dosing is to make sure he's anticoagulated for his chronic AFib. We are suspect of this creatinine clearance because of his losing weight and frailty. So, suspecting that he has sarcopenia, the low serum creatinine of 0.8 is probably not really reflective. Sorry, just eating lunch. And will result in an overestimation of renal function with creatinine clearance and eGFR, I should put, with Cockcroft-Gault and eGFR equations. So if we round, and I know I used to do this clinically, we'll have to ask Dr. Mosler what he does, but I would always round this up to 1. I would never use a number less than 1 in elderly patients, especially if they're losing weight and have any signs of sarcopenia. If we increase this to 1, when we do our Cockcroft-Gault estimate at 71, it actually goes down to 57 by changing this to 1. So it's a significant decrease in our estimate. Reduced renal clearance will prolong because it's cleared by the kidney, but not only 25%, but it will prolong the half-life because of the decrease in clearance, right? The labeling of Eliquis requires dose reduction to 2.5 milligrams BID if greater than or equal to 2 of the following are in play. Age of greater than 80. Nope, he is 73. So he is not greater than or equal to 80. His weight is 73. No, wait a minute, he is 84. Shoot, I'm mixing up my weight. So he's 84. So yes, he is over 80. His weight is not less than 60. He weighs 63 kilograms. His serum creatinine is at 0.8. And even if we round that to up to 1, it's still not in the danger range to consider this to be 2 of the 3. He only has 1 of these. But he also has borderline renal function and frailty. And also because he's elderly, we've got this increased exposure risk. So what should we do? I would leave him the same. Make sure you're watching his renal function really carefully. And this is the direct oral anticoagulant with the least dependence on renal clearance. So it's probably our best choice in this patient. You also need to remember that he's at greater bleeding risk because of his age as well. So I would just watch and wait. But I would be concerned because of his loss of weight if this continues, and checking his renal function frequently. All right, Mrs. Alvarez, 78 years old, prescribed diazepam. We already know that's a bad choice. 5 milligrams at bedtime for anxiety. She's also on lisinopril, amlodipine, and vitamin D. Probably has hypertension. I don't know. What pharmacokinetic and pharmacodynamic concerns exist for diazepam in this patient, and what alternatives would you suggest? Well, we know diazepam is cleared hepatically by the CYP system. And we know that as you age, she's 78 years old, as you age, your CYP system declines in its effectiveness. So the intrinsic clearance will be down, and therefore her clearance will be decreased. Also, this is a lipophilic drug, so the volume of distribution will be increased. So volume of distribution is increased, clearance is decreased. It's going to have a much longer half-life. It's going to hang around in the fat. And it's just a bad choice. So aging increases body fat percentage, decreases total body water, therefore increase in volume of distribution for these lipophilic drugs. Also the decrease in hepatic, as I already said all this, which are prolonged half-life, drug accumulation, sedation, and falls. Not good. So these pharmacokinetic changes and pharmacodynamic sensitivity to GABAergic drugs result in a high risk and delirium risk. high fall risk. Can't even read my own slides. So it's better to go with a phase 2 metabolism benzodiazepine, like remember our lot drugs, lorazepam, oxazepam, temazepam. So we want to avoid long-acting diazepam or long-acting benzos, and we would prefer lorazepam or oxazepam. We'd like her to not be on any of these drugs. So can we manage the anxiety other ways with CBT, relaxation techniques, etc.? If medication is required, we're going to use the lowest effective dose, shortest duration, and monitor for sedation and confusion. We don't want her getting up and walking around during the night when she's, got higher levels of the drug if you're taking it at nighttime. All right, in summary, aging profoundly affects pharmacokinetics and pharmacodynamics. Chronological age does not equal physiologic age. Use evidence-based tools to improve safety in older adults. Emphasize describing if possible. Fewer drugs, lesser drug interactions, less side effects, etc. The body composition changes from more water to more fat as a percentage of their body weight are important, or depending on what kind of drug you have. You want to start low and go slow. You don't want to forget about treating these patients. So don't make it so that you're not actually treating them. Got to find a happy medium. Here are the references that I used in this presentation. I hope you enjoyed it. Thanks. Bye.